Hi there. Welcome to the discussion of brand new cases in the ASAS case library. My name is Denis Poddubnyy, and together with Kai Hermann, it's our great pleasure to talk about new cases in this educational product. Today, we're going to talk about two cases, and you will see why we decided to discuss two cases at once. We'll start with the first one, and this is a case of a 22-year-old male patient who came to us with chronic low back pain for about 1.5 years. So this is assuming that this is axial spondyloarthritis. That would be a relatively short duration of symptoms. You might know that there is a current definition of early axial spondyloarthritis that requires presence of typical symptoms of axial spondyloarthritis for less than 2 years. So we will be exactly in this frame if we find out that this is indeed an inflammatory disease. So let's have a look at characteristics of this back pain. So symptoms improve with physical activity, not with rest. There is night pain with awakening in the early morning hours. The patient reported, however, no relevant morning stiffness and reported also some pain radiation. So partially inflammatory character of back pain, but 22-year-old male subject without any history of trauma is suspective at that instance for the presence of inflammatory problem. He tried already an NSAID, a COX-2 selective NSAID with good symptom relief, and looking at other spondyloarthritis-related manifestations, he had no arthritis, no enthesitis, no dactylitis, no extramusculoskeletal manifestations. He has, however, positive family history with a mother diagnosed with spondyloarthritis. He is studying currently and has some mechanical stress factors, including kickboxing with intensive trainings several times a week. At the next step, we will look at results of the physical examination, and patient was in a good condition, no overweight, investigating spine and sacroiliac joints. There was no clear tenderness over these anatomical regions, and there were no signs of peripheral arthritis or enthesitis, and patient showed normal spinal mobility. Next step, the lab. In the lab, we were mostly interested in HLA-B27, and it was positive, and CRP was borderline elevated, and the patient had no other reasons for elevation of C-reactive protein. So all in all, partially inflammatory character of back pain in a young male patient with B27 positivity and positive family history raises suspicion of axial spondyloarthritis, and we would be really keen to see an objective confirmation of inflammation in the axial skeleton. And for that, we have help from imaging, and I would like to give over to Kai. So what would be, as of today, your first choice of the imaging in such a case, so young male with short symptom duration?
Yes, as you see here, an MRI was performed, and this is also that the best imaging modality that you can acquire in this early phase of the disease. As you know, there are two imaging modalities recommended as a routine diagnostics. The first one is an X-ray of the pelvis, and second one is MRI of the sacroiliac joints. We have also the method of low-dose computed tomography, but this technique is regarded as a problem-solving tool and is usually not performed as a routine standard diagnostics, although many studies have meanwhile contributed to the scientific base of this technique, and could show that low-dose CT of the sacroiliac joint can be in fact done at the dose of an X-ray of the pelvis. So in some institutes, I've heard that radiologists already refuse performing pelvic X-ray and perform pelvic low-dose CT instead. So let's have a look here at this young gentleman. We have this stir sequence, which is an oblique coronal slice orientation. So you see here the general appearance of the stir sequence. First, it's always important to check image quality and coverage of the entire joint. So regarding image quality, you would need to check if the fatty component, which you see here, has a low signal intensity similar of the muscle, in order to be true fat saturation. And there are several parameters controlling this type of fat saturation. There is the inversion time that is used in that is adjusted in the stir sequence, and it needs to be adjusted according to the field strength and a little bit also to the type of magnet. So I would say this is quite good, but it's not 100% perfect. As you see, there's still a higher signal here of the fat compared to the muscle. So some uncertainty is still here, but I think we can clearly see there's some bone marrow edema subchondrally here in the iliac bone, a little bit also in the sacral bone. But I also said that anatomic coverage should be checked, and that is done if you go from slice 1 to slice that's the last slice, to see if the entire joint is captured. So here we see the posterior aspects of the ilium. So for sure, the joint is captured until the posterior aspect. And if you go to the anterior slices, we also see that the ilium is seen here, and there's no joint space here. So this is an example of a perfect coverage of the anatomy. But yeah, I see sometimes scans where the evaluation stops at this point, or sometimes even at this point, and then we miss about 1 to 2 to 3 centimeters anteriorly, and that is sometimes a pity, because there we see a lot of mechanical stress happening with bone marrow edema. Okay, so we see some subchondral bone marrow edema predominantly in the iliac bone, a little bit also in the sacral bone on the right side. It goes up to the anterior aspect of the joint, to the mechanical load zone, so to say, but it extends also in the mid portion of the joint, is quite extensive here in the ilium, and it extends into the posterior aspect of the joint and also affects here the sacrum. As you see, the typical slice framing is not achieved here. So I guess that the long axis of the sacral bone was not perfectly matched here, and this set of images is rather steep. It should have been more tilted to a more transaxial slice position, or to fully meet the standards published by the ASAS. Having a look at the left side, we see some slight bone marrow edema also here. And we have otherwise some also smaller areas of bone marrow edema here in the posterior aspect of the ilium, but there's certainly some asymmetry with more inflammatory load on the right side than on the left side. Regarding bony contours, usually bony contours are looked at T1 weighted scans and also at the wipe sequence. So this patient was scanned without the wipe sequence. It came from an outside hospital and is an historic scan, so it's about some years old now. And but on the stir sequence, it's also worthwhile looking at the subchondral plates. And you can, for instance, here, if you enlarge that a bit, you can see that there might be some, like a gap, small gap here, or maybe small erosion, some irregularity, but this patient is 22 years of age, so still we need to consider some residual growth formation, and I assume that some of his cartilage and apophysis is still not fused. Okay, on the other side also here, there's a nice cortical plate, but sometimes we see irregularity, maybe due to vessels or something else. So having a look at the T1, and here we see that we first need to check the fatty component, which is bright, but also it's worthwhile looking at the disc L5S1, because sometimes you are tricked because a T2 weighted sequence was acquired, and this can be mistaken for T1 if you do not look carefully to the fluid compartment here in the sacral canal. So here we see the right sacroiliac joint again. We see this dark appearance of the ileum, which is due to the bone marrow edema that we already know based on the stir sequence. We see here the normal bone marrow edema, the joint spaces, they look good, the joint contours, and a good finding to search for is also backfill or fat metaplasia within an erosion cavity. So first you would expect some erosions. So for instance here, that is not clear if that is an erosion or if that is related to the transition between the fibrous part and the cartilaginous part, but there's also some fat tissue surrounding it. So indeed, maybe it is a small erosion. And if you look closely and you really have a magnifying glass, maybe you can see some dots here. But I would not refer it in my report as a backfill sign, because I see it as an early case, and I would only report the bone marrow edema. It's worthwhile to have second planes. Here we have the axial plane. So we have a second view, see the joint here, also reconfirm with the fat deposition that we can see here. We can reconfirm that the joint space has no erosions. And then again, we can also use this stir sequence where we again see the joint. And we can see here nicely that we have the anterior joint aspect affected, which is roughly this square, but also the middle aspect and the posterior aspect. So as you know, Dennis, we published on osteitis condensans and stressed the occurrence of bone marrow edema in the anterior slices, but here it's extending into all slices, so that is no question here. There's no, that's not compatible with osteitis condensans. So that would be my take with the MRI. So you would get a report saying there's strong bone marrow edema on the right side.
And you would be saying that this bone marrow edema is compatible with spondyloarthritis, right?
Definitely. Yeah. That is what I would write. Yes.
Very good. So all in all, we have very good imaging confirmation that this case indeed can be diagnosed with axial spondyloarthritis, because we have not only the typical clinical presentation, but also presence of active inflammatory changes compatible with axial spondyloarthritis. Very important to stress that the compatibility of bone marrow edema is very, very important, making the right diagnosis. In this case, we saw not that many structural changes, but we had a suspicion that there might be some structural lesions. And as you pointed out, we were lacking one important sequence, T1 fat saturated gradient echo, like wipes sequence. Do you think we would have seen some erosions with wipe?
So we to summarize it, as a T1 weighted sequence has a slice thickness of maybe 2.5 or 3 millimeters, and it is a spin echo sequence or a turbo spin echo sequence, which means the delineation of the anatomy relies on classic sequences, and also the thickness of the slices leads to some blurring of the contours. If you have a sequence with thinner slices, even a T1 with thinner slices would be sufficient, then you can see erosions at more detail, but acquiring a T1 with 0.6 or 0.8 millimeter slices would take ages. So we need some fast imaging method, and the wipe sequence, which is called LAVA on Philips scanners, and LAVA on GE scanners, and Thrive on Philips scanners, is some fast method with a gradient echo approach. So it's faster to acquire one slice, and also has ability to have thinner slices. So you have in 3 to 3.5 minutes an entire scan of this area. And then you would have a bright signal of the cartilage contrasted to a dark signal of the bone. And I think we would have more a more clear vision into the joint. We would know if this is an erosion or not. We would maybe see also some growth plate cartilage if it's still there. So this would be a tremendous help in this case.
Very good. So all in all, we think that this is a case of early axial spondyloarthritis, and you might see those cases also in your daily clinical practice, especially if early referral strategies are applied in your surrounding. But we still have an issue also of a delayed diagnosis, and that would be a topic of case number 42. So you can now jump in directly to the next case, and we will see you there.
Let's do it. We're going to case 42 and we will meet there again.